All right. Okay. All right. Let's get it going. Okay. So the immune system. So the immune system, when you think about, you got the nervous system, that's just the brain and the spinal cord. You got your cardiovascular system, which is just your heart and your blood vessels. But for the immune system, you have your white blood cells and your lymphatic system and lymphoid tissues where those white blood cells are stored and mature. So immunity, obviously, that's your body's protective defense against any invasion or injury. Um, it's affected by many factors. I'm sure we all know, stress lowers your immune system. Certain medications suppress your immune system or strengthen your immune system. Surgery, obviously, if you're malnourished, that's going to affect your immune system. Temperature, if you're in, when your grandma tells you put a coat on so you don't get pneumonia, there's actually some truth to that, because the cold does slow things down and slow your immune system down. So you have these 5 different white blood cells, and we're going to talk about each one in a minute, but they are responsible for the inflammatory response. They kind of, they kick off the action of the immune system when injury or any intrusion of, pathogens, foreign objects, whatever takes place. Same with lymphoid tissue. Like I said, that's just where the white blood cells are stored, and that's where they mature. So passive natural immunity. Passive meaning it required no action. It was just passed on to you, right? Natural, you came naturally by birth. So these are the antibodies that your mom passes to you at birth and via breast milk. That's why they push breastfeeding so much, because there's so many antibodies passed from mom to baby while she's breastfeeding to strengthen the immune system. All right. And then you have your active natural. Again, natural is occurring inside the body. This is something that your body is doing for itself, but now it requires some action. You've been exposed to an infection or, some sort of pathogen, whether it's a virus, whether it's a bacteria, whatever the case may be. Your body has been exposed to it, and now it is creating a memory and creating antibodies. So the inflammatory response. The inflammatory response can happen. I mean, the inflammatory response is the same no matter what. It's non-specific, meaning if you hit me with a bat, if you stab me with a knife, if I get a hip replacement, or if I contract an infection, the reaction that is going on inside of the body is exactly the same. It is non-specific. So it is a reaction to any injury or invasion. And that involves, it starts with the activation of the neutrophils. We all know inflammation, heat, redness, pain, swelling, but I'm going to tell you why you have heat, redness, pain, and swelling. Neutrophils, those are the most abundant white blood cells there are. You see, they make up 55 to 70% of the white blood cells you have circulating in your body. They are phagocytic. They are responsible for phagocytosis. So you see, like this Pac-Man in the right upper hand corner, what they do, they get in there, they engulf and digest foreign materials. So you get exposed to strep infection, the neutrophils are going to be the first on the scene. You get poked with a needle or burned with a fire, the neutrophils are going to be the first on the scene as far as white blood cells. And in response to infection, when there's an infection, they will reproduce quickly, and then your white blood cell count will go up and your neutrophil count will go up. That's what they call the left shift. So a left shift is when your white blood cells, if you look at the labs on the bottom right-hand corner, white blood cells, these are like the normal ranges. When those white blood cells, the top one is normal, the bottom is the left shift. You see the white blood cells are up, right? They're above 10, which was normal, and now they're 15. But also, when you look at a CBC, and I'm going to show you another set of labs so you know what I'm talking about, because I'm going to show you real labs like you would see at the hospital. But when you see those neutrophil counts with the white blood cell count, then you know it's an infection. Versus if somebody, and we'll talk about it more in a minute, but if somebody's taking prednisone or steroids, it's going to raise their white blood cells, right? Or if there's just inflammation, say it's just an injury, or I have rheumatoid arthritis, say, or something like that, and it's just inflammation, my white blood cells will be up, but the neutrophils are not going to rapidly reproduce. So there are times when you're at work, you're in the hospital, for my LPNs in the building, and you look at the labs and you're like, oh my God, their white blood cells are 15. Let me tell the doctor, they probably have an infection. And the doctor looks at you and they say, no, he doesn't have an infection, or no, it's just inflammation. You know how they know? Because they looked at the neutrophils. They looked at the segs and bands, which are immature baby neutrophils. All right, so so cytopenia means high cell count. Cytopenia means low cell count. Cytosis means high cell count. So neutropenia means you have a significantly low neutrophil count, less than 2,000, and that is going to put you at severe risk for infection. Therefore, that's why we have neutropenic precautions, or sometimes they call it reverse isolation. Those people are going to be on isolation. You're going to wear a gown. You're going to wear a mask and gloves, of course, because you do not want to get this person sick. It's not about them protecting, you're not trying to spread infection to other patients from them. No, it's you protecting them because their immune system is weak. And that's when you're going to tell them no raw foods, no large crowds, don't want to be around any sick people. You can have visitors, but if the visitors are sick, no, they need to stay home. Eosinophils and basophils, we'll talk about them more when we get to allergies, but that's really when they, especially eosinophils, they really get activated with an allergic reaction. That's when they really become, you see them work. But they can be raised with inflammation as well. Basophils are another white blood cell, and they're responsible for releasing chemical mediators. Histamine is a chemical mediator. When you get an injury, or when you are exposed to an allergen or anything, histamine is a chemical that is released out of the tissues, out of those basophils, and it's going to cause your blood vessels to open up and dilate. So if my blood vessels dilate, what's going to happen to my blood pressure? Anybody know?
Go up.
Go up.
Go up.
Wrong.
It normalized because it's desolate. Yeah,
I'm gonna explain it to you, and I'm even gonna show you a video. So, and it's okay. I expected you to get it wrong. So, the vasodilation, think about this. Vasodilation, the blood vessels are opening wider, right? So you went from looking inside a little tiny garden hose to now it opened up like a big old tunnel, right? But think about it. You didn't lose any blood. You didn't add any blood. So the volume of blood is the same. So another analogy I could give you is if I take my 24-ounce coffee from Dunkin' Donuts, right? It's packed tightly in that cup. It's filled to the brim. So the pressure in that cup is higher than if I pour it in my bathtub. I still got 24 ounces of coffee, but now it's in my bathtub. Does everybody understand? That's what's happening. Vasodilation. The blood
Yes.
vessel opened up wide. So now, so a lot of medications you give, the reason they lower blood pressure is because they cause vasodilation. And when you work in ICU, when you're working with sepsis patients, you'll learn about this later on, and we're going to talk about sepsis later. Vasopressors are a type of drug you're giving to cause vasoconstriction. You want the blood vessels to tighten up. You want to go from it being a big old tunnel to a tight little straw, because now that's going to increase pressure. Everybody get that?
Yeah, it's like less work.
Yeah.
Yes. So it's going to lower the pressure, lower cardiac output, everything. So, but in the case of inflammation, and that's why, think about it. So histamine's being released, right, in this inflammatory response. That's why people go into anaphylactic shock. All that histamine is being released is causing all that vasodilation, and now these people are dying. Blood pressure is 60/30. That's why you have shock. So anyway, I just want to explain that to you, because it will help you in a lot of situations, whether you're dealing with a heart issue or anything. Vasodilation lowers the pressure. Capillary permeability. Capillary permeability means the walls of the blood vessels went from being a sliding glass door to a screen door. So now fluid's just flowing in and out. That is so the vasodilation and the capillary permeability, it's doing that to protect you. It's doing that so more white blood cells and more histamine and more other chemical mediators can get to that site and heal it. So more platelets. You need platelets and clotting factors to get to that site and clot if you've been cut. So that is why histamine is doing it to help you. But when you have like a severe allergic reaction or a hypersensitivity, now it's over exaggerated and now it's hurting you. So and then of course that is also why, so now you have your blood vessel opened, blood is flowing to the area. Now you have swelling, now you have redness, now you have heat. Why? Because all that blood and chemicals and everything is flowing to that area. Not only that, but neutrophils and all this action going on is going to cause heat, going to cause fever. And then, of course, if you're swollen, you're going to have pain. Macrophages or monocytes. Monocytes turn into macrophages, and what they do, they are really responsible, like that Pac-Man, for eating up, they're responsible for that phagocytosis, that Pac-Man capability, eating up the bad guys, or eating up dead cells. I mean, our cells don't live forever. They go through, whatever the Krebs cycle, whatever. I'm no biologist, but whatever the case may be, when the cells die, that's when macrophages also move in and just clean up that debris. When the inflammatory process is over and all this mess is left, the war is over, they come in and clean up. They're the first on the scene to act like that. But also neutrophils are the first on the scene, but they're the first to get in there and start, like, they don't talk, they're all action. They're not going to sit and talk stuff with you. They're just going to come in and start eating stuff up. What they're also going to do is they're going to snatch you up and bring you back to the T lymphocytes so they can identify you. And we'll talk about that in just a second when we get to the immune response. But now everything we just talked about, I want to show you this video. So I need everybody to go on mute so that I could really show you visually what I'm talking about when we're talking about the inflammatory process. So if you're not on mute, mute now.
Inflammation is the body's protective response against infections or disease. Inflammation affects the cells to the site of injury, unsuspected pathogens, and eliminates them, and initiates tissue repair.
Okay, you guys can't hear?
No.
Oh,
Yeah, it doesn't let us hear it really well, but I was
okay.
trying to
All
read
right. So
along.
you can watch it at home, but I'm just
Okay.
trying to show you.
Sorry.
Oh, okay. I was
I'm
trying to
sorry.
show you. So
You can
that,
put the hold on, Professor. You can put the link to it in the
yeah,
chat, and we can watch it on our own.
yeah. What I'm gonna do anyway is I'm gonna put a link, page in Moodle while we're on lunch, because I told the class yesterday I was gonna do that with all the videos, the links to all the videos. But you also had the PowerPoint at home, so you can watch the video on the PowerPoint. All right. So anyway, I was trying to give you a visual of what was. Oh, hold on, girl. Be quiet. Hush. All right. I was trying to give you a visual of what you would see. So like this is the blood vessel at the bottom of the screen. And now those cells and everything are being released, right? I mean, yeah, those white blood cells, those chemical mediators, they're all being released. Now, oh, how I get to the, take me to the next slide, Lord. Okay. All right. So you can watch the video on your own. But let's move on. So far, does anyone have any questions? All right. So here's a real, this is what you would see. This is what you would see on labs, right? This is a real, I mean, if anybody works in healthcare, this is exactly what the labs look like when you get them. I mean, it may have different print or whatever, but for the most part, this is what a CBC with differential looks like. So when the doctor tells you, all right, I want a CBC with diff or a CBC with differential, where the red line starts at platelets, that is just a CBC. From the WBC to platelets, that's all you're going to get if you only order a CBC. But if you order a CBC with differential, they are differentiating between all the different white blood cells. All right. So that's where you see that left shift, right? So if that white blood cell count 5.7 was say it was 19 or something, then you're going to look down at the neutrophils. Is it in the appropriate range? Did the percentage of neutrophils go up, or did the absolute count? Because those are just two different ways of counting it. Did it go up? If it didn't, then we know it's probably not an infection. High leukocytosis, remember cytosis means high cell count. So leuko, white blood cells, high white blood cell count is greater than 10.5, and that's per ATI. Depending on where you work, it could be a little bit different. White blood cells less than 4 would be leukopenia. Penia means low. So, and then you see the different diseases that could cause that. Let's move right along. All right, the immune response. So this is the coordinated response of the components of the immune system. So what I just told you about, that's just inflammation, right? But now we're talking about, okay, the macrophage has taken, all right, so some guys showed up in blue shirts, the blue shirt being the antigen, right? So they showed up in blue shirts. Macrophage came out swinging, right? But he also ran back to say, look, T lymphocytes, we got some dudes in blue shirts down here. I need you to come quick and identify these fools, okay? So you have your immune system, which we already talked about. Natural is anything that was created by the body, your innate or natural immune system. You have the artificial immunity that was given to you through vaccines, or if you happen to get an infusion of immunoglobulins. If you get that plasma antibodies for the COVID vaccine, for the treatment of COVID, that whatever convalescent plasma they were giving people, that's another artificial. Even though it came from another man, it didn't come from your body. So it's still going to be artificial. Active is like, it's requiring some work. Active, if it's natural, then it's when your body is making antibodies to after being exposed to a disease versus making antibodies after being exposed through an injection, through a vaccine. And then passive is you didn't have to do nothing. You just laid there and got the stuff handed to you. So whether it came in an IV or whether it came to you by your mom when you were born. Lymphocytes, that's the last white blood cell that we did not talk about before, because they're involved in the immune process, not the inflammatory process. They are the T lymphocytes and the B lymphocytes. They got the T team and the B team. The T team is the first to act. They're going to get out there. The T helper cells, your CD4 T helper cells, that's the name of them. They're going to get out and they're going to identify, okay, these dudes in blue, they're a problem. And not only are they wearing blue, it's blue polo. All right, let me go get the B cells. Or let me go get the T killer cells so they can just wipe them out. And we're going to talk about both processes. So they originate in the stem cells of bone marrow. Bone marrow makes all the white blood cells, right? But then they're stored in the lymphatic system. Everybody knows what the lymph nodes are, right? Like your glands in your throat. When people say, oh, my glands are swollen, those are your lymph nodes. You have lymph nodes that run all alongside your circulatory system. The lymph nodes are little filters. They filter out the blood. They filter out infection. They filter out cancer. So when the lymph nodes become swollen, it's that your body is trying to fight something off, because everything, that's where those T lymphocytes are stored, and that's where they, drag these pathogens and everything. That's where the fight goes down. They bring them there to be cleaned out of the body. So T lymphocytes initiate the cell-mediated immunity. That means the T helper cells, the CD4s, they run and get the T killer cells, and they kill off the infection. Or you have humoral immunity, which is started by the B cells, and that involves antibodies. That's our body creating antibodies. So we're going to talk about both the humoral and cell-mediated immunity, right? So far, everybody with me?
Yes.
Okay, good. I know reading that Lippincott book, you've been and read yourself in a circle sometimes. It seems like a foreign language. So, starting with the...
Sorry, Carly,
Yes, ma'am.
can you please go over the cell-mediated and humoral again?
No, I haven't even got there. I'm about to now. Yeah, I was just giving you a brief, what is it? But now I'm really like this screen right here, humoral response. So
Gotcha.
we're really,
Okay,
yeah, I'm gonna go into it. Don't worry. So this is what's happening, right? Your body has identified an antigen. Antigen meaning like, okay, I've identified a bad guy. However, we'll talk about allergies in a minute. That antigen may not always be a bad guy. Like when your body identifies cat hair, cat dander as an antigen, then you have an allergy, right? So this is what happens in the humoral response. You have this invading pathogen, and it has specific proteins on its surface, right? That's really what the antigen is. So it's the blue polo shirt, right? I have identified this bad guy, and he is wearing a blue polo shirt. And I'm gonna make a blue polo shirt eliminator just for guys in blue polo shirts. What I mean is, one antibody goes to one antigen. You can't get the same, and I can't get a polio vaccine and think that my body's going to make antibodies to COVID-19, right? So your body identifies that antigen. The first part of that is your CD4, your T helper cells. These are lymphocytes. There's different types of lymphocytes, right? These are all white blood cells, but now we're getting even more specific, right? So your CD4, now these CD4 are going to be important when we talk about HIV. CD4 T helper cells are the first ones that say, we got a problem here, and I know who these guys are, and they go tell the B lymphocytes. Cytokines are just chemicals. They're chemicals that are released, like the histamine and things like that. Those chemicals, histamine, bradykinin, those chemicals are cytokines. When you say chemical mediators, they're talking about cytokines. When they're talking about histamine, they're talking about cytokines, okay? So those chemicals get released in the vasodilation, the blood vessels opening up, and they're telling everybody, come on, get down here. We got to fight. The B lymphocytes are now going to rapidly make the blue T-shirt eliminator, right? They're going to make that specific antibody for that specific antigen, right? They're also going to make a backup team to remember that antigen. They're going to get rid of them now. These antibodies, they're going to get rapidly produced, and they're going to fight off the infection now, but it's going to be some other antibodies we're going to reserve in the back in case these guys in blue ever come back. So IgM is, when we talk about antibodies, they are called immunoglobulins. Immune globulins, those are our antibodies in our body. There are, when they're at IgM is going to be released quickly. That's going to be in the acute phase. That is the A team, right? IgM is the first team to go out there. IgG is the type of antibodies that keeps the memory. So if I ever get this infection again, I know how to handle it, right? We know how to handle you boys in blue. Come back around here again. We know what to do this time. We're going to be ready for you, okay? So like if you got, one student on Wednesday said she actually caught COVID-19 twice. So because it can happen, you can get the same virus twice. But she said the second time she caught it, her symptoms were nothing. The first time she was very symptomatic, very sick. The second time she just couldn't smell or something like that. That's what I mean. Your body created a memory. They know how to handle a situation next time. So does anybody have questions about the humoral response?
No.
Everybody understand?
I have a question. For the CD4 plus, is that just a T helper cell, or is that both the T helper and the phagocytes?
All okay. The T helper cells are not a phagocytic cell. The T killer cells, CD8, are. T helper cells are CD4. That they're the same. It's like saying, I don't know, like tomato, whatever. They're the same. It's just another name for them, CD4 and T helper cells. But they aren't phagocytic, so they're not going to eat up and kill like monocytes, like the T killer cells, CD8. You understand?
Yeah, got it. Thank you.
Anybody else? Everybody getting the humoral response and how antibodies, how this works? And you see, can you guys, do you see these, you see the picture at the bottom?
Yeah.
Because my Zoom buttons are covering it up, so I didn't know if you see that too. But you see how each antibody fits only one antigen. Every antigen is different. So they got to make a different antibody to match that. So like I told you, IgM is going to be quickly released initially, right after exposure. IgG is the long-lasting defense, the lifelong memory, or hope. Well, maybe not lifelong. You know, they do say, I guess the immunity could wear off. What they say with the COVID, maybe 1 year or whatever, who knows? But anyway, IgG is the memory. I remember you. I know what to do with you when you get here. IgA You just think of that as the first letter of the alphabet. Those are the ones that your mom passes to you. But I'm not going to test you on IgA, okay? So don't worry about that. There's going to be one question about antibodies, and you should be able to answer it. IgE, we'll talk about that when we get to allergies. That is what kicks off the allergic response. Somebody put something in the chat. Okay. Vaguely. Oh, that was on the, okay. That was from the video. All right. This is a cellular response, cell-mediated immunity. Another thing that happens is CD4 cells, the helper cells, they recognize the antigens, and they stimulate the release of the cytokines. Remember, basophils, those other white blood cells, they're releasing cytokines. Cytokines are being released all over, right? Those are the histamine and the chemicals that are signaling everybody. And the T killer cells, they just come in and they attack and kill. That's it. The other part that the T lymphocytes are responsible for is for suppressing and limiting the immune system. Because again, if you watch that video that I was trying to show, while your immune system is protective in nature, it could get out of hand, and then you end up with an autoimmune disease, or you end up with crazy allergies. So your immune system, if it's working properly, it should know when to stop. All right, we done killed them all. Calm down, okay? Go back home, relax. Or they just keep acting, and you end up like that video was showing you with chronic inflammation if the immune system if the immune process can't stop. So we have passive artificial immunity, right? That is, passive means you didn't have to do anything. It was just passed to you. Artificial means it came from outside the body. So that's going to be when you get immune globulins. You may see when you're working in the hospital, somebody like with a maybe severe like HIV or some severely compromised immune system might be getting IVIG. That's what they call it, IVIG, immune globulins. Or you might give an injection like anti-venom to somebody who's been bit by a snake. That's passive artificial. Now let's talk about active artificial, and that's what brings us to immunizations. What's up?
Can you go back real quick on the passive and explain that really quick again? I kind of missed.
Okay, so passive, right? All right, remember, all right, with the coronavirus, right? Everybody wanted to see, okay, if you had corona in the past, you had these antibodies in your system. And now they're trying to get those people to donate their plasma so that they can give it to other people, right? So it's not like I'm giving you a vaccine. Like if I give you a flu shot, if I give you a corona vaccine, we want your body to produce its own antibodies, right? But if I'm giving you somebody else's antibodies, or if I'm giving you some man-made antibodies, which is called immune globulin, that's just another name for antibodies, immune globulin, right? So these are man-made. They have like medication, basically, that's like man-made immune globulin. Or you could get, with the COVID vaccine, people were getting transfusions of plasma with other people's antibodies. So that means it's passive. The body didn't have to make antibodies. We're just straight up giving you antibodies. And that's what an anti-venom is when somebody has a snake bite or with rabies. You're getting this injection of a whole bunch of immune globulins or antibodies, same thing. They're getting injected into you. So that's passive artificial. Did that make sense?
Yeah, I got it. Thank you.
Cool. All right, so active artificial it's still artificial. It came from outside of your body, but it's going to require your body to also react and do some stuff. So that's what we're doing when we're giving people vaccines. we're kicking off an active artificial immunity. So now comes the immunizations. You are going to need to know your immunizations to for the exam. There are going to be several questions regarding immunizations. I did post the CDC schedule, but for me, looking at that schedule is a little too confusing. So I made this table. And with that, you have what I wanted you to see here is the 2 and 6 months are the same color. Why is that? Because they're the exact same shots. The shots you give at 2 months, you give at 6 months. The 4-month shot is almost the same as the 2 and 6 months minus the Hep B. And then Hep B is the only one you give at birth. At 1 year, that's when you can get MMR, varicella, Hep A, or flu. And then the meningitis, MCV4, and the HPV, those are reserved for older children. So I don't know, what's going to be your best way of memorizing it. I did put some worksheets in Moodle that I emailed you about. Those are from the ATI Pink book. And I also posted the answers so you could, get some practice. But you are going to need to be familiar with when to give the injections. Oh, there's a good mnemonic video on YouTube. See, yeah, you can look up mnemonics, whatever it takes, okay? But for this exam and for your PEDS exam next semester in leadership, you are going to need to have some familiarity with the, why is this not going? With the immunizations. So I'm going to give the same spiel I gave every class. As a healthcare worker, as a healthcare provider, you are a representative of health, right? Our whole thing as nurses is to promote health. Nursing is a science as well as a, share what link? What link, girl? Oh, right, to the mnemonic. Look at me, I'm slow. Okay, healthcare, nursing is a science and an art, right? So we respect the science. We support the science. We need to understand the science behind healthcare and all that. But it's also an art because we know how to care for people like no other. We provide that love and comfort and care and holistic care. So with that being said, it is contradictory and everybody is entitled to their beliefs. You are who you are outside of work. But remember, you are a nurse and you are a representative of healthcare outside of work, and it is contradictory to be an agent of healthcare and be anti-vaccines. There are diseases that have been eradicated from the world, from this country, all due to vaccines. Now, I understand right now we're living in a strange time and people are pretty uncomfortable with getting a vaccine that just came out, including myself, and that's fine. But you do not share that with patients, and you do not go out there. People look at you in and outside of your career for advice and for guidance. How many people in your family have asked you for medical advice since you started nursing school? Soon as you got in the school, you became the family doctor. So it is contradictory. There is no science behind saying that the MMR or whatever vaccine causes autism. There is nothing supporting that. So do not go out there preaching that to people. Children need these vaccines. Because more and more people are going against vaccines, we're seeing a recurrence of diseases that haven't been diagnosed in decades. So it is important that we educate parents about vaccines. And sometimes some people just don't know. A lot of people these days get all their information from Twitter and Facebook. They don't know. Nobody reads. Polio. Thank you, Ashton. My 5th grade teacher had polio as a child. Her hands were completely deformed. She had to write with her pinkies. People used to make fun of her. We're kids. We didn't know. But she explained to us that everybody in her class, when she was in 5th grade, had polio. Everybody did. And that's why I'm showing you guys these pictures, so that you can see the devastation and what can happen when you don't get your vaccines. So Hep B, obviously attacks the liver. Somebody got something to say?
Yeah, like like there are a lot of people out there, like especially the doctor in Miami that he said they said that he got a vaccine, the COVID vaccine, and died. I mean, are those like just
The one doctor in Miami out of the
mhm.
millions of people that got it. But for me, I understand, like, the polio vaccine that we have now is not the first polio vaccine that ever came out. So that's why I say right now, when we're talking, that's why I told the class yesterday, pretend I'm not talking about COVID, because I don't have any information. I'm not knowledgeable enough about COVID to talk about COVID. And honestly, I'm not working in direct patient care, so I haven't gotten COVID vaccine, because I just don't work with patients. But the one guy that did die, the doctor, I also read that he had idiopathic thrombocytopenia. So again, you have an underlying condition. That's an autoimmune disorder that destroys your platelets. Your platelets make blood clots. He died from bleeding. If you already had an underlying condition, if one person, the news loves to hype stuff up. Just like, I mean, even still, the percentage of people that have died of COVID is still very small, but they love to let you know when entire families die of COVID every second they get. So, anyways, so right now, let's just pretend COVID is not in the equation. It's not going to be on your NCLEX because it's just too new. So for Hep B is it causes inflammation of the liver, liver failure. That's the picture you see at the bottom right. It is the first vaccine you get at the hospital. The newborns are not discharged from the hospital without getting their first Hep B vaccine, unless, of course, the parents decline any vaccines. However, any of these illnesses, also, if a baby caught it, you can guarantee they're going to die. So diphtheria, tetanus, and pertussis. I'm trying to look up the iron lung because I forgot that too. I know what somebody put in the chat asking about the iron lung, and what was it used for. I'm trying to think, was it pertussis or what was it? But either way, these diseases were devastating to children back, in the early 20th century. Oh, you Googled it. Well, polio. It was polio. Okay, good. All right. So the DTaP, that's going to be the one you give small children. Why? Because pertussis and diphtheria, those are the pertussis especially can be devastating to an infant. Versus as an adult, you only need the TD or the Tdap. It's more important to cover you from the tetanus than anything else. But diphtheria is the main agent in the one for small children. And you saw the schedule. They get it, based on, look on that chart. Tdap, you just get one dose I didn't put Tdap on that chart. So write Tdap in at 11 to 12 years old. I forgot to put it on there. I noticed it yesterday. But you get that at 11 to 12 years old. And then you guys know when people get injured or whatever, they give you a tetanus shot, or when you're going to nursing school, you want to keep it up to date every 10 years. You want to give it to pregnant adolescents. Why can't I change screen? Here we go. Polio. So like I said, like my 5th grade teacher, her hands were so deformed. In some of these underdeveloped countries where people don't have access to vaccines like that, these people still have a lot of these conditions. So this is a picture of children with polio and what that can do to them. It is 4 doses, and you can watch the schedule for that. The rotavirus causes severe diarrhea. But after 15 weeks, if they haven't received it, they don't need it. It is an oral vaccine. It's not a shot. But the rotavirus is still very much alive. I've known parents and kids to get rotavirus. It's just the fact that little babies, infants, severe dehydration, I mean, they crash quickly. So it doesn't take much for a little tiny baby to become severely dehydrated. And then this is H. influenza, which causes that lymphadenopathy, swelling, swollen lymph nodes. Oh, okay. See, Brittany says was that Brittany? I popped up and went back down. Somebody just said they had the rotavirus, unfortunately. Pneumonia vaccines. You got the PCV13 and the PPSV23. Just remember the 13 is smaller. Yep, Brittany was on a cruise ship. She got the rotavirus, so you definitely could catch that. The 13 is a smaller number. It's given to smaller people, right? So that's the one you give to children, and they get it in 4 doses. But if you, for whatever reason, you have an adult who's never received it, then they can get 1 dose. But the pneumonia vaccine you give them moving forward every 5 years, like for older adults, is the PPSV23. And you give that every 5 years to those that are at risk. Oh, Lord. Where's that? Where's my thing to change the screen? Okay, meningitis. These are the signs and symptoms of meningitis. Your meninges, we'll talk about it more when we talk about neuro, but that's the protective lining layers to your nervous system. They protect your brain and your spinal cord. What somebody say? So meningitis, definitely people can still get meningitis, right? But we don't want them to get that, obviously. The ones who are going to be at the highest risk for meningitis are going to be those that live in close quarters. So students in dorms, in college, they're going to be the ones at highest risk. Homeless people living in close quarters, inmates in jail. So this is why we do talk to teens. We do administer the meningitis vaccine to teens in a series of 3 shots when they're going to college. Or depends, nowadays they have so many different brands of these drugs that you can get a one-time shot or whatever. But all you need to know is you're going to give it once when they're 11 to 12, once at 16, and you're definitely going to make sure before they go to college that they have had this vaccine. Don't need to worry so much about the MPSV4. You probably will not see that on a test. I've never even really heard of that. But
Really, do we have to know about the other one, the PPSV23?
I don't think you do need, I mean, that honestly, the pneumonia is the vaccine you're going to see the most in your career. Unless you work in peds every day, you can probably never see these vaccines again. But pneumonia, influenza, and shingles, you definitely are going to see those. When you do an admission, no, adults can catch rotavirus from their kids too. It's just, it doesn't make them very sick. It doesn't affect adults like it does kids. But when you do an admission in the hospital, that's one of the things you are going to assess. When was your last flu shot? When was your last pneumonia vaccine? So I don't think there's anything specific on the test for pneumonia. I can't remember, but you do need to know.
So
23 versus 13. One is for
Okay.
older adults, one is for small children. That's it.
oh, okay, that's the difference. Okay.
Yeah, just know the 13 is for kids, 23 is a bigger number. That's for adults.
Okay.
And both of them are to be administered every 5 years, right? Both the 13 and the 23.
No, when you give an adult the 13 one time, and then you give them the 23 every 5 years.
Oh, okay.
Giving adults the 23.
Okay.
But yeah, you give the pneumonia vaccine. I mean, it's not going to hurt them if you gave them the 13. You give the pneumonia vaccine every 5 years, though. The varicella, right? Varicella is chicken pox, but also you have the zoster, which is the shingles. Same virus, but the other thing you need to know for these vaccines, just the big things like when not to give them. So for these vaccines for older children, this is just how I remember it. If it's safe to give to an infant or a small child under 1, then it's safe to give to a pregnant woman. But if it's not safe, if it doesn't start till 1 year or older for bigger kids, it's not safe for pregnancy or breastfeeding women. Oh, there you go, PG-13, right? Okay, varicella, yes. So the thing with that, you're not going to give during pregnancy. You're not going to give if they've been on antivirals within the last couple weeks. For example, if an older adult catches shingles and they get treated, they're going to come in, they're going to have shingles. It's going to look like that on the picture. And it's very painful. They're going to get treated with like herpes medicine, right? Like acyclovir. Those are antiviral drugs. You have to wait, like they can get a shingles. You want them to get a shingles vaccine after that. You don't want them to go through that again because they can definitely get shingles again. So you want to wait like a month or so after the treatment before they can get the herpes zoster vaccine, which is shingles. MMR, main thing you want to know, that's not given until 12 months, 1 year. So if you see a test question asking you about shots for a 3-month-old or a 6-month-old and it says MMR, because the way these questions are laid out, even on NCLEX, it's not just going to ask you one. It might say you have a 3-month-old or a 4-month-old, whatever. What vaccines do you expect to administer? It's going to give you 1, 2, 3, 4 different vaccines. But if you see MMR for anybody under 12 months, know that answer is wrong, right? And you're not going to give it during pregnancy, no matter what. If the woman is not immune, it doesn't matter. She can't get that vaccine during pregnancy. Shouldn't be giving breastfeeding women live viruses either, like the live flu vaccine. All right. HPV. HPV affects males and females. For some reason, there's this misconception out there that only women are affected by HPV. HPV causes genital warts, and it can lead to cervical cancer. It's like one of the main cause of cervical cancer. Cervical cancer can be easily prevented with pap smears and with HPV vaccines. So if you think about it, HPV is related to sex, right? It's a sexually transmitted infection. So just think about that. It's given to those older kids. You start talking to the adolescent years, 11 to 12 years old. Parents don't like to think about that because they don't want to think about their sweet little baby having sex. But look, it's 2021, okay? They're playing songs like WAP on the radio, okay? You got to talk to these people and you got to catch them early. before they start getting out here and doing dumb stuff. So the HPV vaccine should be given around 11, 12, 13 years old in 2 doses. But if they're older when they get it, it's 3 doses. For the sake of ATI, it says that it can be given up to 26 years old, but one of the students in another class works in a pediatrician office, and she said it actually, I think, goes up maybe to 30. I'm not sure. I'm not a pediatrician, okay? I'm just going to teach you what ATI says. I promise you they're probably, if they ask you about giving a 45-year-old a HPV, then you know that's wrong, but I highly doubt they're gonna you're going to be asked, you know, what's the cutoff age for HPV? But for ATI says it's 26. Let's see, influenza, last thing, it's live. You have the live version and you have the inactivated version. The live version, you're not going to give to anyone who's immunocompromised, who's pregnant, under you know, a certain age. You're not going to give them under 2 years old, or you're not going to give them the live version, because that has a higher risk of making them sick. You're not, I know it's 2021 and they do make a different version of the influenza vaccine, but you still need to know. Most doctor's offices don't have the one for people who are allergic to eggs. So if the patient's allergic to eggs, you need to know that for influenza. Everybody good on the immunizations?
Yes.
All right. All righty, moving right along. Alterations in immunity. Let's go back to that inflammatory response that's going on in the body. Allergies occur when your body, for whatever reason, has identified normal, regular, delicious shrimp and things like that as an antigen instead of just delicious shrimp. So your body has taken this regular item and a regular product, substance, whatever, and identified it as an antigen and created antibodies to remember the antigen. So every time it comes in contact with that antigen, it's gonna go ham, right? IgE is that immune globulin, that is that antibody that is responsible for that whole process, right? Oh, sorry, my sister keeps texting me. Okay, but histamine is the substance that's being released. So the IgE is going to stimulate those mast cells or basophils. Basophils are the white blood cells that are responsible mostly for releasing these chemicals. All the cells do it, but that's like the main thing the basophils do. So it releases the histamine again, right? Histamine is released. We got the vasodilation going on again. We got more chemicals being released. We have capillary permeability. So now we have redness, erythema. We have hives from the swelling and the on the chemicals and everything going there. We have contraction of smooth muscles. So when the muscles are contracting, now you have this vasospasm going, bronchospasm, sorry, going on. What I want to show you, you can see my mouse on the screen, right? Even though this is a picture of an airway, just imagine you're looking into a blood vessel for a second. So this was what I was trying to get you to imagine when it goes from vasoconstricted to vasodilated. But now this is just your bronchus, your airway. So there's bronchoconstriction and there's bronchodilation. That's what your albuterol is going to do. It's going to open it back up, right? So you got the blood vessels are opening up. And now here's all this, the red around here, that's that blood rushing to the area, right? You got blood rushing the area causing swelling in the airways. You got blood cells, these white blood cells coming to the area to help. Eosinophils coming in, and you got mucus being secreted. That is why now air is trying to get through this tight little tunnel, and you start hearing wheezing. Eosinophils, again, like I said, these are the little blue dots. That's the eosinophils. These white blood cells really come into play for allergic reactions. And this is what's happening in the lungs, but also the same thing's happening up under the skin. The skin, you know, that's why you're having swelling in all weird places, making those hives. Prostaglandins. We talked about prostaglandins last week. What the prostaglandins did is they carry a message to the brain about pain, right? You get poked in the finger, it kicks off the inflammatory response. Prostaglandins run to the brain, tell your brain, hey, it hurts, my finger's hurting, or hey, get your hand out this fire, it's hot as Hades up in here. That's what the prostaglandins do. That's what I told you last week, right? That's why NSAIDs work. They stop the production of prostaglandins. The other thing prostaglandins do is they enhance the work of histamine, those chemical mediators, that inflammatory response. So that's why we call them non-steroidal anti-inflammatory drugs, NSAIDs. So they're stopping that production of prostaglandins and slowing down that release of those chemical inflammatory and chemical mediators. Leukotrienes are another chemical mediator, right? Leukotrienes are like histamine, but leukotriene is going to be more potent when it comes to the lung effect. They are more potent in producing mucus in the lungs and in the bronchi, and more potent at causing that bronchospasm. So anybody who has asthma, or if you remember from pharmacology, or if your kids have asthma, there's a drug called Montelukast or Singulair. Singulair works by stopping those leukotrienes. Bradykinin. So when we talk, again, I just keep repeating myself because I want to make sure everything makes sense. Bradykinin is, again, a chemical mediator, aka a cytokine. These are all the same. These words could be used interchangeably. Chemical mediator, cytokine, histamine, leukotriene, and now you got bradykinin. Bradykinin increases vascular permeability even more. So that screen door, it's opening up that door. It's increasing the permeability even more and making the vasodilation even worse, right? That is what's going to lead to that anaphylaxis, hypotensive effect. Everybody understand?
Yes.
Wait, no. You
No,
said
that's all right. What do you need me to
So the
break down?
leukotrienes and the bradykinins. You said there's another one. There's 3 of them. There are chemical.
And histamine.
Other histamines. Okay.
So histamine is that main one. That's going to be the first on this scene as far as chemicals. You know, the neutrophils are cells, but chemicals just being released from the injured tissue are going to be histamine, leukotriene, and bradykinin. Histamine, just think about it. What are you going to give someone for an allergic reaction? You're giving them antihistamines. Benadryl is an antihistamine, right? Leukotriene really just kind of act on the lungs. So that's why you got that drug Singulair, Montelukast. That it's more like people who have severe allergies, people who have asthma, because asthma is not an infection. It is a chronic inflammatory. It's a chronic inflammation of the lungs. We'll talk about that in the next slide. But so the leukotrienes, the histamine is the most prominent. And then there's leukotrienes and bradykinin. And if you're getting a lot of bradykinin release, then you're going to be in anaphylactic shock, because that's going to cause that system-wide vasodilation. Everybody remember ACE inhibitors from pharmacology?
Mhm.
What is the most severe adverse effect of ACE inhibitors?
Isn't it cough?
No, severe. That is a
Oh,
common
severe.
one. Like, what's the most severe?
The vasodilation.
Yep. What do they call it? Angioedema? Angioedema. When people's tongue and lips swell. It happens randomly. You could be taking lisinopril for 20 years, all of a sudden have an angioedema effect happen, right? Where you're like about to die. Your tongue is taking up your whole mouth, your lips are swollen. That is because of the way ACE inhibitors work. They cause bradykinin to be released. Bradykinin causes vasodilation, thus lowering the blood pressure, right? So that's what we want the pills to do. But sometimes it could just go out of hand and cause this all of a sudden crazy vasodilation and lead to that extreme swelling and angioedema.
How does that happen? Like the angioedema with like the vasodilation, how does that cause angioedema exactly?
Okay. All right. So back to the inflammatory process, right? I'm gonna go back a few screens. Well, we were talking, okay, or look at this picture, right? The redness, the four characteristics of inflammation is going to be redness and even infection. Redness, heat, swelling, and pain, right? When the blood vessels dilate, it's bringing more blood to that area or whatever. So that's what causes the swelling. That's what causes the redness and the heat. Is more blood is going to that one area. And for whatever reasons, all of a sudden, that bradykinin, it's just like it's something just triggers in the body, and it's almost like an allergic response. But it's because ACE inhibitors do cause the release of bradykinin, whereas ARBs, and the angiotensin whatever receptor, whatever, you know what I'm talking about. The ARBs, they don't release bradykinin. That's why they don't cause angioedema. So if a patient comes in, they're on lisinopril, their tongue was swollen, you're gonna be like, the doctor is gonna, say, stop taking lisinopril, start taking losartan. Losartan is an ARB, and it doesn't release bradykinin the way lisinopril does, ACE inhibitors.
Okay.
That has nothing to do with your test, but I'm just trying to make you understand, tie everything together.
Yeah.
So, does anybody else have a question about this screen, allergies, or anything thus far? No question is a dumb question either. Like I said, I came to nursing school straight out the OG, the Olive Garden, okay? I didn't know nothing. Okay? So any question is a good question. Because somebody else, I guarantee, is sitting down thinking, oh, I'm so glad somebody else asked that. I'm not here to judge. I'm not here to prove to you, like I told the class yesterday, I'm not here to prove to you I'm the best nurse in the room, because I am the best nurse in the room. I'm the only nurse in the room, shoot. So I'm not here to make anybody feel dumb. So if anything we've talked about thus far is confusing, say something anytime. Stop me when I'm speaking and ask me a question. Yes, Kanisha, that's right. Don't care how stupid you sound. Just ask. It's okay. I don't know anything but nursing. So when we start talking about government history, anything outside of healthcare and nursing, I don't know a darn thing. Okay, sports, I don't know nothing. So we all have our strong suits. One day you guys are gonna know all this. You're gonna be teaching.
Professor Cook, just to clarify, when it comes to prostaglandins, so I understand when, like, if you put your hand in a fire, it's telling the brain, okay, your finger, like there was trauma to that tissue. For an allergic reaction, is it kind of letting the brain know that there's an antigen in there in your body, or the T cells have already told your brain that? I'm a little.
So the T cells are what are doing that, right? Prostaglandins are more important in the pain
Okay.
in pain, right? Prostaglandins are more important there. But when an allergic reaction happens, I'm just showing you there's a chemical reaction going on inside your body all over.
Okay.
The T cells and the monocytes, right? The monocytes, it's like a chain reaction, right? The monocytes get there. Monocytes are macrophages. Just think they both start with M. They get there and they run and tell the T cells. The T cells, the T helpers, CD4 cells, run and tell the T killers. They go get back up. They run and tell the T killers, and they run and tell the B lymphocytes.
Okay.
Got
Thank you.
it? Okay.
Yes.
So in an allergy, the only thing I was just trying to show you was that these chemicals are being released. And really, as long as you're familiar with the chemicals that are being released, like histamine, you have a broad idea of what histamine does, what bradykinin does. Again, you guys are not going to school to be a surgeon. You're not going to school to be some molecular biologist, okay? All you need to know is, okay, an allergy, my body, what's happening in an allergy, my body identified something normal as something bad. It's created antibodies and memory, and this chemical reaction is happening. Histamine and bradykinin are being released, and they're causing vasodilation. Vasodilation is causing more blood to come to that area and result in swelling and pain and redness, and it also has the potential to cause a low blood pressure. That is it. That's all you need to know. When it gets down to the cellular, like all this stuff, it's not gonna be that in depth, because you're not going to school to be a doctor. But you do need to understand, like when I'm giving girl, what am I talking about? When I'm giving albuterol or montelukast, when I'm giving a patient a medicine, I do need to understand how that medicine works. Everything you do in school, remember, you're not going to school to be a chemist, a physicist, okay? The most important thing you need to know is, what does this mean for me as a nurse at my job? What does this mean for me keeping the patient safe and educating patients? So trust me, you are never going to sit down and be talking to a patient about bradykinin and this and that, right? You're just you need to know the very basics. The name, all right, bradykinin. Trust me, I am an advanced practice nurse. I write prescriptions and everything. I just came from being somebody's primary care provider for the last couple of years. I don't know half these words. I got to go back and read your book and remind myself, what the hell is that? I know histamine and bradykinin, but I'm just saying, it's a lot of stuff you're not going to remember. It's not for you to know. What you really just need to know is what these diseases look like, what the basics, what's going on in the body, and how the medications work, and what kind of complications and things to look out for. How can you keep the person safe? It's not your job to know at a cellular level what's going on. You're not a damn pathologist. You can go back to school and learn more about that. I don't even know enough to teach you that. It's not going to be as bad as you guys think, but Lippincott will have you feeling like a rocket scientist. So that's why I want to try to break stuff down in the most simplest terms. Anaphylaxis, hypersensitivity, and the atopic triad, right? So this is not in your book, I don't think, but atopy, or the atopic triad, and many of you may already have kind of put this together. Asthma, eczema, and allergies is what they call the atopic triad. Asthma, eczema, and allergies. They all go hand in hand. It's all a hypersensitivity thing going on in the body, an exaggerated immune response. Like basically your immune system is doing too much. Okay, that's all it is. And most people who have, say, people who have more severe, I'm not talking about you had asthma till you were 2 and you've never used an inhaler. I'm talking about the people who are using nebulizers at home on the regular. People who have severe, moderate to severe asthma usually have allergies, and they usually have eczema. All 3 usually go together, or they may have 2 of the 3. Why? Because if their immune system is just, it's always doing too much. Okay. So that's just what I want you to know. Atopy is that IgE mediated response. Allergies, the allergic reaction is mediated by immunoglobulin E, IgE. When you do blood tests to check allergies, a RAS test, you're looking at the level of IgE is what you're looking at. So we said histamine was that main powerful chemical being released during this allergic reaction. Therefore, to stop it, we need antihistamines, Benadryl. Or there's also hydroxyzine, known as Atarax, if anyone's familiar with that. Atarax, or they also call it, what do they call it? It starts with a V. Crap. But hydroxyzine is the generic. Is it Vistaril? Vistaril is the other name. People take it for anxiety. All it is an antihistamine. It just makes you sleepy like Benadryl. But it blocks the action of histamine. Some histamine lives in your gastric secretions, and that is why you need Pepcid. Famotidine is a histamine blocker. So that's how it reduces the gastric secretions. But if anybody has severe allergies, you ever went to the emergency room or you've seen someone treated for a severe allergic reaction, they're going to get all 3 of these drugs. They're going to get Benadryl. They're going to get some form of a steroid, either prednisone or IV Solu-Medrol, and they're going to get Pepcid or Famotidine, same drug. People always are like, why the heck did they give me, I came here for hives and they gave me heartburn medicine. It's not for the heartburn, it's for the antihistamine effect. Corticosteroids, we'll talk about those more next as we get to autoimmune disorders, but they suppress the immune system, therefore calming down that inflammatory effect. Questions thus far? On to transplant rejection. Transplant rejection. Okay. All you really need to know is it's the same as like allergies. Your body is identifying that transplant as a foreign body. It's the same as if you get a knee replacement or a hip replacement. Is everyone familiar that those people need to be on blood thinners at first when they get a some sort of joint replacement? Or if you get a artificial valve, cardiac valve replacement, you're going to be on blood thinners for life. Why? Same thing. When your body identifies something that doesn't belong here, it is going to kick off this response. Part of your immune response, part of your inflammatory response is also to bring clotting factors to the area, to the scene. So when you get cut or bopped upside the head and now you got an injury here, it's going to bring clotting factors also with the inflammatory process to hurry up and clot up so I don't bleed to death. So when somebody gets a foreign a total knee replacement, for example, that's what the body is like, what the heck? This ain't my knee. Who's this? Where'd this thing come from? All right, I know what to do. We're going to kick off a response, including bringing in clotting factors, and they're going to clot around that joint that didn't belong there, according to the body. Eventually, the body gets used to the joint, but with a transplant of an organ, it's a little more serious than that. So if I just got a kidney transplant, my body could potentially identify this as not belonging here, right? What the heck is this? How'd you get here? Where you come from? And you need to get up out of here. When the surgery first occurs, it could be a hyperacute response where the body begins attacking immediately. That's going to be apparent. It's going to be obvious. And that patient's probably going to be going into shock or something like that. And that's going to mean we need to replace this organ immediately. If it's more of a slower process and it doesn't come on maybe after a couple weeks, it can be reversed, hopefully, with medications. Most people will get a transplant anyway. I think it's common. I don't work in a transplant center, but I've never really seen anyone. Well, yes, I have if they've had it for years and years. But usually when people get a transplant, they're going to be put on anti-rejection meds, like I can never say this word, tacrolimus, also known as Prograf, anti-rejection meds. All they do is suppress the immune system. Corticosteroids suppress the immune system and keep it from getting crazy and trying to destroy that organ. If I got a new organ, what's gonna alert you that my body's rejecting it?
Would it be like fast heart rate?
An increase in your white blood cells.
Maybe those two could be right, but actually it's going to be a sign of organ failure. If I got a new kidney and this is a healthy kidney you just gave me, my kidney function should be restored, right? I shouldn't have to go to dialysis anymore. Shoot, life should be beautiful. But if that kidney, if they're going back to looking like a dialysis patient, that creatinine and BUN starts going up. They're unable to void. They're not making urine anymore. Then they're going to be, you're gonna know, okay, something's going wrong with this kidney. It shouldn't be failing, so likely it's failing because it's being rejected. Same with the liver. If a patient got a liver transplant and now their liver enzymes are going up, obviously the body is rejecting the liver. So we need to come up with a plan. For these people, you really just need to know, when anyone's on any kind of drug that's going to suppress their immune system, now you got to worry about what? Infection, right? So moving on. So just like allergies, autoimmune disorders are the same in that it's a heightened immune response. And now the body has identified its own cells as abnormal. There is 1,000,001 autoimmune diseases. We'll talk about more as we get to different systems. Like we'll talk about Hashimoto's when we talk about thyroid. I'm not going to sit here and tell you about every single autoimmune disorder in the world. It could take all year. But psoriasis is one that affects the skin. Crohn's affects the intestines, things like that. But if you understand what's going on, the treatment for the treatment, you could get Humira for Crohn's, you could get Humira for psoriasis. The treatment is the same. It's all about suppressing the immune system. There is no cure. You're going to have this autoimmune disease for life. The goal is to control the exacerbations or flare-ups and to prevent, them from happening as often. So let's talk about lupus. Lupus can either be cutaneous, affecting the skin, or it can be systemic, affecting the whole body. You see, if everyone's familiar with the singer Seal, a lot of people are obsessed, like, what's wrong with Seal's face? Like, I don't know why everybody is always tripping on Seal and his face, but he has the discoid lupus. He has the cutaneous version of lupus that affects his skin. So he doesn't have the kind that affects the organs, but it does cause like that harsh rash, it causes lesions on people's skin, they can be really ugly lesions. Not ugly like I'm calling the man ugly, but you know, if it was yourself and you're seeing these lesions, you're going to be distressed, like, oh my God, especially on your face. The butterfly rash that can happen with either type of lupus. So then there's the systemic. The systemic is much more devastating, especially because it affects younger women. And I don't know why my crazy behind put 40 to 20 instead of 20 to 40, but it affects younger women, mostly women who are minorities, African American, Native American, Hispanic, Asian, but they're at higher risk. It can come from your genes if your mom had it, if your aunt had it, or it can come from your exposure to various, you know, crazy things in the environment. It is exacerbated by sunlight exposure. So we'll talk about that in a minute, but you need to talk to patients about protecting themselves from the sun. Like I said, the main thing, so almost every autoimmune disorder causes fatigue. Almost every autoimmune disorder may cause some low-grade fever, some joint pain. So that is not specific to lupus, but what is specific is the rash for sure, the butterfly rash, the lesions it causes on the skin, the alopecia. Some other disorders do cause alopecia, but not for the sake of your exam. It is prominent with women with lupus. Those are the two big ones. And then the fact that the most horrific complication of lupus is the kidney damage, lupus nephritis, which causes inflammation of the kidneys and leads to kidney failure. A lot of these young women sadly end up on the transplant list. It's usually when someone dies from lupus, it's usually from the kidney failure. The diagnostic testing. Now, again, you're not going to school to be a rheumatologist, right? You probably don't need to know all these. It's good to know, but as far as when you're working in the hospital as a nurse, you're probably only going to see an ANA drawn. ANA is simply that's just anti-nuclear antibodies. That's just saying my body is making antibodies against itself. So an ANA could be positive with any autoimmune disorder, but it usually, not always, but it's usually elevated. It's usually up with lupus. And that's the one you usually see positive. I think it's positive like 90% of all lupus. But anyway, it's not just because the ANA is positive doesn't mean the patient has lupus. So that's all I'm trying to say. You'll need these other more specific tests, but those are going to be done by a rheumatologist. A rheumatologist is a specialist who specializes in lupus. The erythrocyte sedimentation rate, ESR and CRP, which we'll talk about next. ESR and CRP are inflammatory markers. They are going to be elevated no matter what the source of inflammation is. And ESR will be elevated with someone with lupus. It will be elevated when they're having an exacerbation or flare-up of lupus. It's not specific to lupus. It'll be elevated if you stub your toe or whatever. You have an infection in your toe, it could be elevated. It's not specific to lupus. However, if you're treating a patient, if a patient's in the hospital with a lupus exacerbation and they're getting meds, the doctor's going to watch the ESR to see that they're getting better. Because I can't keep testing. It's not like the flu or COVID where I could retest you and see that the COVID went away. You're always going to have lupus, but at least I know the inflammation is lowering, so I know the medicine is working. BUN and creatinine. BUN and creatinine are kidney function tests. You're going to monitor those because obviously lupus causes kidney failure. So you're going to watch that. You don't want that to happen to the patient. A urinalysis with positive proteins and blood. You should never have protein or blood in your urine. In either of those, if you see any element of red blood cells or protein in the urine, you're already going to suspect something is going on with the kidneys, whether it's a UTI or whatever. The only time you will see red blood cells in the urine and it should be normal would be if a woman was on her menstrual cycle. Of course, there's going to be some blood, and I'm talking microscopic. I'm not talking about you look at the urine and you see blood. I'm talking about maybe the urine is amber colored and then they do the test and they tell you there's RBCs in the blood, in the urine. But otherwise, you should never have blood or protein or ketones. None of those things should be in your urine, or glucose. But we'll talk about that more later down the road. And then CBC, pancytopenia. Cytopenia means low cell count. Pan means all. So pandemic means the whole world. Pancytopenia means your white blood cells, your red blood cells, your platelets will all be low. And because lupus is a disease of the connective tissue, the body is attacking connective tissue, it can cause nephritis and pericarditis or myocarditis. It is inflaming the lining of the heart and the lining of the kidneys. So now to say it will be normal, the keto diet is not normal and it's not healthy, but would it be expected finding? It could be. It could be ketones, protein. Like I said, don't worry, I just made that statement now, but when we go to kidneys, we'll talk about it more. But like you could have protein and ketones in your urine. She asked if a patient has ketones in their urine, should we ask if they happen to be on the keto diet? You can have protein and ketones in your urine even after a rigorous workout or if you're dehydrated. I'm not saying you're never going to see it there. I'm just saying textbook purposes, you never should see it there. But mild dehydration, probably right now, I probably got ketones in my urine because all I do is drink coffee and not enough water. So I'm not saying, oh, if you see protein in the urine, the patient's about to drop dead or needs dialysis, but a normal, textbook, normal urine should never have blood, protein, ketones, none of that in the urine. So education for lupus patient, we'll talk about meds later because the meds are the same with every autoimmune, but avoid stress. Obviously, stress is gonna weaken the immune system, cause an immune response. Protect them from sunlight. They need to wear long shirts, wear hats, all that. Monitor for edema or hypertension. Those could be signs of heart problem or kidney failure. So monitor for that. If they do have edema, they need to maintain what? Low sodium diet. They need to watch how much water they drink if they have edema. Monitor for fever, signs of infections, obviously, because they're going to be on some type of medicine to what? Suppress the immune system. And then you're going to teach them to use mild hair products because they're losing their hair too. Skin, keep it clean, keep it moisturized. That's for everybody. You need to moisturize your skin. It helps maintain skin integrity. Another autoimmune disorder, most common along with lupus, is rheumatoid arthritis. This one attacks synovial tissue. It attacks the protective lining and areas surrounding the joints. Then over time, later on, it leads to deformity of the joints. It can cause, usually it affects multiple joints. It could be in one hand or it could be in both hands. It could be in one knee. It could be in both knees. but it usually affects multiple joints at a time. Once again, like lupus, I don't know if you just think about us women as being sensitive, hypersensitive, but for whatever reason, autoimmune disorders, a lot of them, rheumatoid arthritis and lupus especially, affect women more than men. These women are a little bit older than the women getting lupus, 30 to 60 years old. However, like after 60, pretty much anyone can get it. You'll see men and women, older men and older women, both with rheumatoid arthritis. Could also be, genetic, passed on to families. The other stuff there, it could be caused by a virus. The main thing to differentiate rheumatoid from osteoarthritis, the pain, well, one, osteoarthritis, it can cause deformities, but not as often as the rheumatoid does. But the other thing is the pain from rheumatoid arthritis is usually worst in the morning. Pain can occur even at rest, whereas osteoarthritis is more like wear and tear. So the pain for osteoarthritis, when we get to musculoskeletal, osteoarthritis, like old Arthur that all the old people talk about, that is wear and tear. So the pain is usually at the end of the day after you've been walking around and doing your household chores and all that. So the pain with rheumatoid arthritis is in the morning. It occurs at rest. So of course, after you've been asleep all night and the joints have been sitting still, the pain's going to be the worst. You're going to be stiff. Once they get going during the day, usually the pain lightens up for rheumatoid. Joint deformity is a late sign. So if I'm 35 and I'm just now coming to you with complaints of fatigue, morning stiffness, joint pain, joint swelling, you're not going to expect to find my hands to be looking like that picture in the last slide. That's after you had rheumatoid arthritis for a long time. Pleuritic chest pain may occur with pleuritic means it's just inflammation in the chest wall. It's not necessarily pain in the heart like with lupus, pericarditis, myocarditis. It's more like the connective tissue between the ribs and stuff. Pleuritic chest pain. Pain when you're breathing in, breathing out. Pain with the lining of the lungs. But not actually heart chest pain. Xerostomia, dry mouth. One of the complications of autoimmune disorders, it's in your ATI book, is Sjögren's syndrome. Sjögren's is excessively dry mouth and dry mucous membranes, dry mouth, dry eyes, and dry vagina. Nobody wants that. And then the other clinical manifestations, like I said, are non-specific. Again, that ANA may be positive because this is an autoimmune disorder. So anti-nuclear antibodies may be found in the body. But rheumatoid factor is more specific. And then there's even more specific tests than that. But you're not a rheumatologist. You don't need to overwhelm yourself trying to remember all these crazy tests that you're never going to see at your job. Like ESR, we already talked about. CRP, C-reactive protein, is another inflammatory marker. It can be elevated with any type of inflammation in the body, any type. Same with ESR. So while it may not tell you exactly what's going on, it could help with monitoring the treatment and stuff and seeing, is this person in a flare-up or is the medication working or whatever. You may do x-rays to look for those deformities, and then synovial fluid analysis. That's like putting a needle in the joint space. That's going to be done by like a rheumatologist or orthopedist. And they draw out some fluid and analyze that. That's obviously going to be much more detailed, much more specific tests than these blood tests if you're actually going to the source, to the joint. Increase, you're going to tell them about light exercise, yoga, tai chi, walking. Nowhere on any nursing test, anywhere really, are you going to be telling patients to do like strenuous exercise with no disease. It's always going to be something like walking, water aerobics, something like that. And for these people, to their ability, because they already have this joint disorder, but you do want them to stay active so that they aren't if they're sitting still longer, the pain's going to be worse because the pain is related to the stiffness. Monitor for pain, monitor for the side effects of medicine. The diet should include high protein, vitamins, and iron for patients with rheumatoid arthritis. Protein, vitamins, and iron. That only reason I put that on there is because it was on the exit exam at one point. Students were being asked about the diet with rheumatoid arthritis, but in all actuality, that's like, I don't know why ATI picks and chooses things that are important to them, but the main thing is the physical activity and watching for side effects of drugs that are suppressing the immune system. This table here is just showing you, what the two have in common. And like I said, this Venn diagram, the ones in the middle, pretty much go for any autoimmune disease that affects you systemically. Treatment for autoimmune disorders. No matter what the autoimmune disorder is, the treatment is going to be based on reducing the immune and inflammatory response and stopping the symptoms. So NSAIDs, what do? They fight inflammation. They stop the production of the prostaglandins, slowing down the signaling to the brain about pain, slowing down the your perception, knowing, the perception of pain and feeling pain, and the release of histamine, bradykinin, and other cytokines. Corticosteroids, that could be prednisone, or if you have eczema, it could be topical. It could be triamcinolone, betamethasone. A steroid is a steroid, okay? They have different levels of potency, but they all are basically doing the same thing. They are reducing inflammation by suppressing the immune response. Adverse effect, it can cause kidney damage, just like NSAIDs. So if you have a lupus patient with kidney damage, one, you're probably going to be leery. You're not going to be advising them to take NSAIDs. You're probably going to steer away from that because it can cause kidney damage. Why? Because the NSAIDs are filtered through the kidneys. Remember, drugs filtered through the kidneys can cause kidney damage. Drugs filtered through the liver can cause liver damage. But if it's filtered, like Tylenol's filtered through the liver. So if someone has kidney failure, they can take Tylenol. There's nothing wrong with their liver. So corticosteroids, again, now you have to look at risk versus benefit. And that's what the doctor will decide. Is it more of a risk for them to be on corticosteroids and worsen their renal function? Or is it more of a risk not treating them with the steroids and letting the disease worsen their kidney function? Other side effects. Remember when I was talking about the left shift, it can elevate your white blood cells. Prednisone can cause the WBC to go up, but it won't cause a left shift. So that's how someone can look at the labs and say, okay, I know they have leukocytosis, elevated white blood cell count, but they don't have an infection because there's no shift. Also, steroids cause your blood sugar to be high, hyperglycemia. You need to use these with caution in elderly people, and the dose cannot just be discontinued suddenly. It needs to be tapered down. Immunosuppressant drugs and DMARDs, there's all different ones. You know, there's Enbrel, there's all these ones. They just came out with a new one, a new injection for eczema. I see for eczema and asthma now. They have this Dupixent, something like that. It's a commercial. You see it all the time. That's a DMARD. It is a disease-modifying anti-rheumatic drug. Basically, it's a suppressing the immune system. Just like methotrexate. Methotrexate is cytotoxic. It kills cells. It's like chemotherapy. It's used for people with cancer. But it also is used to slow down the immune system. So the side effects when you're giving it to someone for chemotherapy, you know, the immune suppression, that's what we want for these people with this hyper autoimmune disorder. So of course, again, if you're lessening the immune system, if you're weakening the immune system, you're going to look out for infection, and you're not going to give these people live vaccines. And then there's anti-malarial agents. Everybody knows this. This is a household drug now. Hydroxychloroquine and Plaquenil. Same drug. All it does is reduces, it's an anti-malarial drug, but it's used for autoimmune diseases because it reduces synovitis. It reduces that joint pain and the swelling in the joints and the inflammation in the joints. It reduces their pain. It doesn't, you know, do anything else but that. And it does, it does also think, they think it has an effect on the way the sun causes damage and causes flare-ups. Any question about autoimmune, lupus, rheumatoid arthritis before we go to HIV? Cool. HIV will be quick, and then I think I can get through all of it by 12:15, and then we'll get to lunch, and then we'll come back and review for the test. All right, caused by retrovirus. That's it, that's all. You don't need to know all the specifics and everything. You're not a microbiologist. Just know retrovirus because the name of the drugs that treat HIV are called antiretrovirals. So it is a retrovirus. It infiltrates CD4 T helper cells. So that is why HIV can have such a devastating effect on the body, because your body can't even identify that it's being invaded. The CD4 T helper cells, they're the ones that say, all right, these are the boys in blue polo shirts. They are identifying that this doesn't belong here. This infection doesn't belong here. So when those get killed off, your body is at its weakest. Today's open up the floodgates. Anything that comes in here can wreak havoc on your body and cause infection. That's why HIV patients, if they're not being treated, can get all these opportunistic infections. And we'll talk about that in a second. So for the sake of learning, because I read your books, I read them talking about the 4 stages of HIV, except stage 4. We don't know anything about stage 4. So how do you know there's a stage 4 if you don't know no information available? That was confusing as hell to me. And when it comes down to it, HIV, you can bounce between stage 2 and stage 3 for the rest of your life. So it doesn't just happen like this. It is in stages, yeah, if you don't take any medication and you just allow yourself to get to AIDS. But for the most part, it's 2021. People are living forever. Everybody with HIV can be Magic Johnson. So in the beginning, when you're first infected, HIV, the symptoms, they may in the acute phase have flu-like symptoms, you know, fever, night sweats, body aches, headache. They may have that, or they may not. So we can't say every single person who contracts HIV has that, because remember, everybody's body responds to disease and creates illness differently. So in the acute stage, you may see flu-like symptoms, but the symptoms are going to go away. Latency. People could be asymptomatic for more than 10 years, 20 years. I mean, people could live with HIV not knowing they have it for quite some time. Latency. It takes time for the body to create anti-HIV antibodies. When I give you a test for a disease, if I'm checking you for COVID, right? All I'm looking for is to see, does your body have antibodies to COVID? That IgM antibodies, the antibodies that are actively working, right? That's all a test is. You're looking at antibodies. Now, when they draw the blood for the COVID patients, they're looking at IgG. They're looking for the memory antibodies. But either way, if you've never been exposed to a virus, you should not have antibodies in your body, right? So your HIV is going to be positive if your body has anti-HIV antibodies. I've never had HIV or been exposed to it, so I shouldn't have any HIV antibodies in my body, right? That is HIV positive. And with the way HIV works, it gets in the T helper cells, it divides inside there, it gets in there and works on their DNA and changes it, and they take over the cell. And now the cell is dividing, and the drug and the HIV is dividing, and as it's dividing, it's spreading more HIV, but it's also killing off the T cell. So that is why in the beginning, it takes about 6 months to a year before somebody can find out, usually 6 months before you can find out you're HIV positive. If I have a sexual encounter tonight with someone who's HIV positive and I go get HIV tested next week, I probably won't be positive, right? If I get stuck by a needle at work and the procedure usually is the hospital, they may offer you medicine to prevent the HIV infection, but they're usually just going to test the blood of the patient, because there's no point in testing you right now, because it takes time for your body to make those antibodies for the humoral response. And your body responds to every disease differently. The late stage, or AIDS, we'll talk about AIDS in a minute, but that's when the patient becomes severely immunocompromised. AIDS is not a disease. AIDS is a syndrome. A syndrome is a collection of symptoms, just things, all this stuff going on, but you can be at AIDS status and then get out of AIDS status. You can have a CD4 count less than 200 and then raise your CD4 count. Opportunistic infections. Does everyone know what an opportunistic infection is?
No.
No.
Okay, good. That's all right. That's why I'm here. So, opportunistic infections mean these infections usually only come around when the immune system is compromised. Opportunistic infections can be mild, like a vaginal yeast infection. A woman's been on penicillin for a week for strep throat. The penicillin killed off the good bacterial normal flora in the vagina, and now you have an opportunistic yeast infection coming in. C. diff is an opportunistic infection. Most of us, I mean, it is highly contagious, but most healthy people have good normal flora. So Even if you caught, say you work in healthcare, person's on contact isolation, you know, you see your coworkers all the time. People don't follow the rules, you know, nasty people when you see them. But they don't catch C. diff. Why? You know, that one person, you never see them wash their hands and they never catch C. diff. Why? Because C. diff is an opportunistic infection. It's only really going to be able to survive and attack when that good, healthy, normal flora from your intestines is killed off. So if you've been on heavy duty antibiotics, there are infections, thrush, oral thrush. Most adults, I mean, babies get oral thrush. Why? Because they're newborn babies. Their immune system is weak. They have no immune system. Versus you see a grown person with thrush, it's likely something else might be going on besides just thrush. Either maybe something. They might be on a steroid for lupus, and now it's lowered their immune system and caused them to get thrush. But fungal infections a lot of times are opportunistic. There are infections that only pretty much affect patients with HIV and no one else because their immune system is that weak. Again, this shouldn't happen in the year 2021. And we'll talk about that when we get to treatment.
I had a question.
Yeah.
It might be a stupid question. I might ask.
No.
Like how you're talking about like a needle stick, like in the hospital. If you got stuck by a needle or from a person who has HIV, so you're talking about how it takes like a while to actually like multiply and spread. Are you able to stop that? Like, is the hospital able to stop that from you getting like HIV? Like if he's caught like a needle?
Yes. No, that wasn't a stupid question. So that's why like the new drug on the market, the PrEP, right? Truvada. Truvada is not a new drug. That's HIV pill. That's all it is. I've been passing Truvada to patients since I graduated in 2009. Truvada is an HIV medication. When we were talking about immunity, right? Your immune system has the potential to fight off anything, right? If it's equipped. So your immune system, even you could get precancerous cells. Like people get HPV and let's not nobody raise their hand or anything. That's pretty personal. But I don't care. I put my business out there. I've been to the doctor. I have had a pap smear and been told that I had precancerous cells. They tell you come back in 6 months, those cells are gone. Why? Because your body, your immune system has the ability to fight off anything. Cancer. If your body is strong, it could fight off cancer. That is why health is so important, people, health promotion. So in the case of a needle stick, if I start taking Truvada the day I get stuck by a needle, my body's already ready. Bring it, HIV, I'm ready. You're not going to have the chance to multiply up in here because I'm already on medication. I'm about to kill you off. So that's the way PrEP works. It is thought that it is going to be able to kill off, even if you were to come in contact with HIV, it's going to kill it off before it has the chance to multiply. Does that make sense?
Yes, it does. Thank you very much.
You're welcome. So yeah, so if you get a needle stick, they will offer you Truvada or one of them, some HIV medicine, they will offer it to you. But they will also, like I said, they will check the patient and make sure, is that patient HIV positive or not? They may do that. But they'll likely have you coming back to occupational health, in 3 months and 6 months, just to make sure you are HIV negative. And that's the other thing. The thing about HIV, really likely, a doctor once told me, and now I've learned, it really takes repeated exposure, and it's also determined when we talk about infection next. Actually, I think after HIV, well, let's see, we could go to lunch now or we could wait. We'll see. But when we talk about infection, it also depends on the viral, the virulence, the amount of that virus. If the person you were exposed to is taking their meds and their viral count is low, the likelihood of getting it from one isolated sexual encounter with them is also going to be low. Versus if that person, like, CD4 count is killed off and their HIV viral load is sky high, you may be able to get it from them after one little needle stick. That's why they say, I mean, a lot of these people who end up HIV positive, and not always, but a lot of people are at higher risk because they're sharing needles regularly. They are having promiscuous sex, like maybe you're, you're living in poverty and you're a prostitute. You're exposed multiple times throughout the day to multiple partners. That's why those people are at higher risk. When people shoot up, they probably tend to hang out with the same clique of people. They're shooting up with these people every day. You're repeatedly injecting dirty needles into your arm. So usually HIV is more than just a one night stand and I caught HIV. The spread of it's spread by bodily fluids. I mean, you guys are grown adults. Everybody knows HIV is spread through blood and vaginal secretions and semen. While it can be found in saliva, it is not transmitted by kissing. It is not transmitted by touching someone's hand, shaking someone's hand, giving them a hug. Okay? So ELISA, you do need to know these tests. The ELISA is the initial rapid test done in clinics and health fairs. That's the initial. Western blot is the confirmatory test. So while the ELISA is pretty reliable, you still, if they've only had an ELISA, you got to do a Western blot to confirm that this person has HIV. Once you've confirmed they have HIV, now we need to know, how bad is it? What is the viral load? RNA quantitative is the same as a viral load. Another example, like what I just was talking about, Hep C. We'll talk about hepatitis next week. But Hep C, for example, a person can get a blood test and be positive for Hep C. But when you do the viral load, the RNA quantitative, they do not need treatment because their immune system, although it has come in contact with Hep C, it did not cause everybody go on mute. Everybody mute who got a dog barking? Yeah, get that dog out of here. Anyway, no, but that's the viral load. Same with, like, when people technically say, oh, my HIV is undetected or Hep C undetected, it's not that you don't have the disease anymore. It's just that your viral load is so low, it's basically almost undetectable. It doesn't mean you don't. Well, now Hep C does have a cure, but your HIV viral load you're always going to be HIV positive. There is no cure. And now, another patient brought up the Germany patient, the one patient in Germany who had a stem cell transplant, who they did think was cured of HIV, but he also died of transplant rejection. So they weren't sure, was it the transplant rejection that killed the HIV, or was it the stem cell transplant itself? Look, stuff that is still being heavily researched, those aren't facts. Until we can go into a clinic and tell patients, hey, there's a cure for HIV. No, there's no cure. Get that out your mind, okay? You got HIV, you're on HIV meds for life, and you have HIV for life. But You can live forever just like a normal healthy person if you take your medicine. And that is why it is just so sad to see anybody die of AIDS or HIV related illness, because it's so preventable. It is the thing that kills people in 2021 is the stigma and the shame that people feel when they become HIV positive. And we need to change that. We're nurses. We need to change that stigma. Just like why people don't get treated for mental health issues or drug addiction, we need to stop being so hard on people. So unprotected, you know what's going to spread HIV. So I don't even need to go over
I
that.
have a question.
Yeah.
So usually the people that die from like AIDS, it's because they like didn't catch it in time, so it's kind of like already, you know.
Oh no.
So that's why they
No. The reason people die is because their immune system, they usually die of another infection. But even so, trust me, by the time you get to the hospital, even with that infection, they're going to find out you can go from, that's why I say, let me show you the next slide to show you what I'm talking about. This is a before and after. The after is on the right-hand side. You can go from AIDS status to a healthy status. That's how good AIDS treatment is. It is 2021. But what happens is they do get these infections, and the immune system is so weak by that time. Yes, you can't catch it. But most people have had symptoms way before that. They know they're HIV. A lot of people know they're HIV positive and refuse to get treatment. That's how bad it is.
I have another question.
Go ahead.
How does like Magic Johnson? He has AIDS, right? Does he just?
He has HIV. AIDS is not a disease. AIDS is you have HIV, but right now your CD4 count is either less than 200 and you have an opportunistic infection, or you just have an opportunistic infection. Opportunistic infections, I'm going to go on the next screen, but I'm going to show you there are certain infections that literally will only affect people once they are so immune compromised that CD4 count is down.
Okay.
So like 2 years ago, right, one of my friends called me. She wanted me to come to Longwood Hospital in Fort Pierce. Her sister was there. Her sister's in her 30s. And they thought her sister was having all these weird neurological things. They thought she was having like minor strokes. So she was at the ER, and she even in the ER had a seizure. Well, when I got there and I saw her sister, I was like, either she is like strung out on, drugs, or something's going on. She didn't look healthy. Well, she ended up being HIV positive. Her CD4 count was 8, not 800, 8. So when I say less than 200, it qualifies you as AIDS status, right? Now, she's back at work. She's a medical assistant. She's on her meds. Everything's good. CD4 count back regular, living in an apartment by herself. The treatment for HIV, this is 2021. It's not 1987. The treatment is so good. I tell patients all the time, I would much rather have HIV than any type of cancer. Cancer is so unpredictable compared to HIV in 2021. Antiretroviral therapy, ART, or what do they call high action or high something, antiretroviral therapy. Anyway, those are the meds you're giving people to fight HIV. Usually 3 or 4 drugs are going to be combined, because the last thing we need is some super HIV that's resistant to medication. So it may be 3 to 4 pills you're giving the patient. It may be 1 pill with 3 drugs in it. So I don't want you to think, well, I have a patient and I give them 1 pill. Yeah, but that pill, if you look at it, is probably a combination drug. Medications are taken for life. You're going to monitor for side effects of the meds. Because HIV affects the DNA of the cells, then you have medication that's going to get in and affect the DNA of cells. So it can lead to aplastic anemia, elevated liver function. It can cause elevated cholesterol. You need to know the general side effects of HIV meds. Bactrim is an antibiotic. I can't pronounce all that. Trimethoprim, sulfamethoxazole, Bactrim. You may see patients with HIV taking it regularly. That is to prevent pneumocystic pneumonia, PCP. We're going to talk about that next. So a patient may be like, look, I'm healthy. I'm not sick. Why am I taking Bactrim? That may be a question on your exam. Well, it's to prevent. It's prophylactic. Prophylactic means prevention. It's to prevent pneumocystic pneumonia, which is the #1 infection that kills HIV patients. IV gamma globulin. That's just, again, those IVIG is what they call it, the IV antibodies being given to newborns if they're born to a mother with HIV. Or if they're born to a mother with HIV and you're not sure if the newborn has HIV or not, then you're going to give them the Bactrim too, to make sure they don't get an opportunistic infection. HIV should always be referred to infectious disease. It should not be managed by a regular doctor's office. This is a specialty. There are HIV clinics. The health department in every county in the United States is working to treat HIV for free. Homeless people have access to HIV medications. There are no reason why people should be dying of AIDS in 2021. And so because of that mental health support, reassuring these people, linking them up with support groups, showing them you are not alone, because that's what kills people with HIV, is the stigma and the shame. Here are opportunistic infections. This is what I'm talking about. Thrush. You see that oral thrush on that patient. That candidiasis is the fungus that causes thrush. You see that, it'll be horrible, severe, painful. They may have it all down their throat and be unable to eat. That is because of the low CD4 count and the weakened immune system. They can also get certain cancers, B cell lymphoma, B lymphocyte lymphoma, and also Kaposi sarcoma. That's the middle picture with these markings. Kaposi sarcoma, Kaposi sarcoma looks like almost like scarring, bruising. They're purple lesions that appear on the skin, but it also can attack the lungs and other parts of the body. But it is a cancer specific to HIV patients because their immune system, like I said, the immune system does have the potential to fight off cancers, but their immune system is so weak that, probably the rest of us, our immune system is strong enough to fight off Kaposi sarcoma, I guess, because it really only occurs in patients with HIV. So people with AIDS have HIV. People with HIV, just because you have HIV doesn't mean you have AIDS. So people tend to use the two terms interchangeably, but it is not the same. AIDS is a syndrome. It is just a condition, a collection of symptoms happening. Sepsis, we'll talk about that next, is a syndrome. Any infection in the world can cause sepsis. So saying, oh, what's wrong with the patient? They have sepsis. Okay, from what? They have sepsis. You'll sound like a real idiot because sepsis is just a syndrome. You could say they're septic, but you also need to be aware of what is the infection. Like they have, people will say urosepsis. They had a UTI and it led to sepsis. So HIV can lead to AIDS, but you can go back to just being regular HIV status. So that's the misconception. So to be AIDS, you have a CD4 count less than 200 and the presence of an opportunistic infection. But if any patient with HIV has an opportunistic infection, regardless if their CD4 count is 500, but they have pneumocystic pneumonia, they are considered AIDS right now. They're having AIDS, their AIDS status.
Like a collection of infections.
Right. It's just symptoms, infection, whatever. It is a presentation of that, a collection of clinical manifestations or clinical presentation, but it's not specific. Like sepsis, like I said, is not specific to one infection. Like this is just a syndrome that can occur with patients with HIV, but it is false to say that all people with HIV have AIDS, because they don't. Or that they're even going to get AIDS, because they may not.
You can't die of HIV, you die of the infection that's caused by AIDS.
Right, exactly. Most people do not die of HIV. They die because their immune system is weak, and then they get that opportunistic infection, whatever the case may be. Same with as if someone's on chemotherapy. Same thing. You're on chemotherapy, it killed off your immune system. You could die of a cold, a common cold. That's
So
why
if I'm sorry, if I have HIV and I'm experiencing HIV symptoms and then I get like bacterial pneumonia, I will have AIDS, but I can come back from AIDS to going back to HIV once that's all regulated again.
Right. You won't be having that syndrome anymore. You're still
Okay,
HIV.
okay.
You're HIV with AIDS. You're always going to have HIV. It's just now you don't have the AIDS anymore. You're good. You're cleared. Back, your CD4 counts up, pneumonia is cleared up. You're HIV. You're just HIV positive.
So is it only medication that makes your CD4 count and like your viral load fluctuate, or is it like more than that? Is like medication compliance? I guess that's my question.
Well, that's the main thing. I mean, HIV is not going to be treated with diet and exercise. So without medication, your CD4 count is going to be destroyed and you are going to get sick. However, just like anything else, immunity is affected by multiple things. So you're still going to teach these people to live a healthy lifestyle. Anything that's going to lessen your immune system, is probably going to make the medication less effective. So if you're out here still shooting up and you're still, starved, you're not eating properly and you're not exercising, you could be on the medication and still have your viral load going up and still have your what's it called? CD4 count going down. Hold on. I'm sorry. I'm just making sure this isn't a student calling me. Hello? Hello? Yes. Hey. The Zoom is in Blackboard. I mean, I'm saying Blackboard, Moodle. It's on Moodle. Yeah. Oh, okay. He didn't tell me that part. Moodle wasn't working this morning. Ah, okay. Let me email it to you. I'll email it to you. Okay. Bye. All right. Sorry about that. Okay. So can one of you guys do me a favor? Well, you'd have to have her info, huh? Never mind. I'll email this student the Zoom link, but this is the last screen and I'm about to let you guys go to lunch anyway. What were we talking about? Any questions about this, how this goes with the opportunistic infection?
Yeah, I have two questions.
Hmm.
Okay, so one of them, for the HIV, what was the CD4 count for that? Was it the same?
Oh,
Was it-
HIV, I mean, the goal is just to be, you want their CD4 count to be whatever a normal CD4 count
Okay,
is. Like, I think it's like, what, 800? Don't quote me. 800, something like that. All you need to know about CD4 count is you need to know that AIDS, less than 200, they are now AIDS status. They are immune, totally immune compromised, and they are going to have a very hard time fighting off infection with a CD4 count less than 200. That's the only number you need to know.
okay,
As long as you know 200, less than 200 is bad, you know any number above 200 is okay, and any number below 200 is bad. That's all you need to know.
okay. And back to the when we're talking about pregnancy, so if a woman has like HIV or AIDS and she's pregnant, is it automatically just transferred to the baby, or is that
No,
where those medications come in?
nope. Look at Magic Johnson. He got kids. They're not HIV positive, nor is his wife. So
Okay,
probably back in the day, they were probably taking PrEP or something like that back then. But yeah, you can, the mother, if the mom was actually HIV status, she would still take antiretrovirals during pregnancy.
okay,
Oh yeah, see, Jenny has a friend whose mom, yeah, there's plenty of people whose parents are HIV positive. And that's why I say, like, HIV is so, we have come such a long way since 1930, I mean, not 19, since 30 years ago, 1990, when AIDS epidemic first happened. So, it'll be cool to see what they do, like with COVID, to be able to say, hey,